Hello friends, I'm Dr. Farheen, your OBGYN faculty at Aakash PG Plus. Well, I will not say that it was a very easy paper. Some of the questions were straightforward in OBGYN, but many questions were really very tricky. Okay, so best of luck for your results. Let's start discussing the questions here. So the first question is, what is true about primary amenorrhea? What is primary amenorrhea? It is defined as failure to reach menarche by 15 years of age group and failure to reach thelarche by 13 years of age group. And if the menarche has not occurred after the development of breast, even after 5 years. So this gap is 5 years. Okay. Now the confusing part is, as per the Indian guidelines, the age group differs a bit. This is 16 years and thelarche is 14 years. Okay. Now going back to the question, what is true about primary amenorrhea? No menarche at 15 years? Yes. No thelarche by 13 years? Yes. A gap of more than 3 years between the two? No, this is a gap of more than 5 years between the two. So therefore the answer will be A, 1 and 4. Going to the second question, SRY gene is located on, so the answer lies itself in the question, S and Y. So it is located on the short arm of chromosome Y. Another question, they were fixated with this SRY gene in this exam. Amniocentesis revealed 46XX, okay, it's a female baby, but ultrasound revealed that it's a male baby. So there was some problem and the diagnosis was made of 46XX with complete gonadal dysgenesis. Now, as per the options, we can say that there is some problem definitely with the SRY gene, but what is the problem? So there is deletion of SRY gene, but this deletion is associated with 46XY complete gonadal dysgenesis, and that was a little disconnect which I felt while taking the exam. As per me, this should have been 46XY. Now, which test is of least significance in Mosaic-Turner? First of all, let's see what is Turner and what is Mosaic-Turner. So in Turner syndrome, what is happening? That the chromosome is 46XO, which means that in a female, all part of the cells are lacking one X chromosome, all cells, okay? In Mosaic-Turner, what happens? That few cells are 45X and few cells can be 46XX also, okay? So few cells have complete chromosome, but few cells are lacking. So therefore, the manifestation in Mosaic-Turner is much milder than what is seen in the Turner syndrome, okay? Now, what all organs are affected in the Turner syndrome? So the heart is affected, eyes, bones, and kidney. These are the main things which are affected. Is Turner syndrome an autoimmune disease? No. Turner syndrome is not an autoimmune disease, but there can be a chromosomal mutation in it and it can at times be linked with systemic lupus erythematosus, but it is not always linked with that. Now let's go through the options. Should we get an echocardiography done? Yes, we should get it done because it is affecting the heart. Audiometry? Yes, because it is affecting the ears also. OGTT? Yes, we should get it done because the carbohydrate metabolism also gets altered, and OGTT is the best method, and the glucose tolerance test is the best method to detect any abnormality. What about anti-nuclear antibody? Now, anti-nuclear antibody is only done in cases when autoimmune disease is associated with Turner syndrome. They have not mentioned anything like that, so therefore this will be our answer. What is primary dysmenorrhea? So primary dysmenorrhea is when the pain starts at least 1 day prior or at the start of the menses, and it can be there for 48 to 72 hours. Dysmenorrhea can be of two types. It can be primary or it can be secondary. What is the difference between the two? In secondary, there will be a pathology. There will be a pathological factor, and in primary, there is no pathological factor. So generally, this is seen in adolescents when they start with their menses. Okay, so when they start with their menses, it is seen in them, and it can happen for around 1 to 2 years from the start of menarche. So no pelvic pathology is there. The pain starts 1 day prior. It can continue to 2 to 3 days. What is the first line of treatment? So the first line of treatment is NSAID. Also, oral contraceptive pills can be given. So GnRH is not the first line of treatment. Can psychological factor be associated with it? Not really. And this is definitely not the answer of choice. Okay. 28 weeks primary with fibroid, fever, and mild leukocytosis. What is the cause? So this is a very straightforward question, and the cause is red degeneration of the fibroid. All are given in endometriosis except. Now this was a tricky question, okay? So let's go through the options. The management of endometriosis, there is medical management and surgical management. Going with the medical management first, so we give NSAIDs, we give GnRH analogs, we give continuous combined oral contraceptive pills. What is the basis of this medical management? That we have to stop her cycles. Yes, we have to stop her periods so that whatever the endometriotic tissue is being shed and getting deposited outside of the uterus stops happening. progesterone oral, injectable or Mirena, anything which is stopping her cycles. Okay, antiprogesterone danazol can also be given. And what is the conservative surgery which is preferred? So laparoscopy is the gold standard. If patient has very dense endometriosis, or if there is an endometriotic cyst, then laparoscopy is the gold standard. If a patient has completed her family, then she can also go along with hysterectomy. Now the two confusing options here were whether to give capgolin or estrogen valerate. Okay, now I went through and looked through my books. So treatment with capgolin suppresses cell proliferation and vascular endothelial growth factor, and it is one of the drugs which is being used to treat endometriosis. Okay, what is the aim of hormonal treatment? Again, it is to stop the production of estrogen, and as estrogen encourages endometriosis tissue to grow and shed. So limiting estrogen is going to limit the problems associated with endometriosis. Coming back to the options, capgolin can be given, leuprolide and progesterone acetate definitely it can be given, GnRH analog, this is GnRH analog, and this is your progesterone. Talking about estrogen valerate, it cannot be given alone. Had it said that oral contraceptive pill, we could have gone along with that, and then answer would have been capgolin. But since it alone mentions estrogen valerate, therefore our answer will be that. Non-immune hydrops fetalis is seen in all except. So what is immune and what is non-immune hydrops fetalis? First, immune hydrops fetalis is when the mother's immune system causes the baby's red blood cells to break, and it is a very dangerous complication. It leads to hemolytic disease of newborn. A lot of fluid accumulates in the extravascular space, in the third space. So there is pericardial edema, there is pleural effusion, there is scalp edema, the Buddha sign is there, right? So the cause of immune hydrops fetalis is ABO incompatibility, and rest all can be causes of non-immune hydrops fetalis. Okay, so this was a straightforward question. Infection with least likely perinatal transmission. This was also a little tricky question which makes us think. So we have to think that which is the infection which is mostly affects the first trimester and wanes out as the pregnancy progresses. So there is only one infection in which this is happening, and that is rubella. Okay, cytomegalovirus can also, there is increased transmission as the pregnancy progresses. Hepatitis B, definitely it is bloodborne and it can cause perinatal infection. Herpes simplex virus, well, if it is a primary herpes, then vaginal delivery is contraindicated, right? We go for a cesarean section. If it's a recurrent herpes, then we need not worry about that. But they have not mentioned over here whether it's primary or whether it's recurrent. So therefore the answer of choice is rubella. Infection which causes high output cardiac failure. It caused anemia, myocarditis and ascites in the baby. What is the most common cause? Okay, now let's go through the causes one by one. Treponema pallidum, syphilis. In treponema pallidum, we see a Hutchinson triad. Okay, there is interstitial keratitis affecting the eye. It affects the teeth, malformed teeth, also known as Hutchinson teeth, and eighth nerve deafness. This is a pathognomonic of syphilis, treponema pallidum. Also, one more sign they had asked in the previous INI-CET, Kasowitz rule. So, what is Kasowitz rule? That as the patient's pregnancy increases, as her gravidity increases, the prognosis of the baby becomes better. What do we mean by this? Suppose in the first pregnancy, when she was pregnant for the first time, there was a stillbirth at 24 weeks. Then in the second pregnancy, it can happen that the stillbirth is around 36 weeks. In the third pregnancy, the baby is born fine, but there is perinatal death. And in the fourth pregnancy, the mother has a healthy baby. So this is Kasowitz rule, which they have also asked in syphilis. Talking about cytomegalovirus infection, as the name suggests, C, there will be chorioretinitis, this is the triad, M, microcephaly, and V, periventricular calcification. Sorry, periventricular calcification. What is seen with toxoplasma infection? With toxoplasma infection, all these things are there, but the main thing is hydrocephalus. And instead of periventricular calcification, there is diffuse calcification. And now what is the presentation with parvovirus infection? With parvovirus infection, there is anemia, there is myocarditis, and very pathognomonic if they mention high output cardiac failure. Okay, so coming back to the question, what is the answer? Parvovirus. It is not treponema pallidum, not toxoplasma or CMV. Okay. Then the most common cause of pubertal menorrhagia. This was a very straightforward question. The most common cause is anovulation. Malignancy is not a cause because it is pubertal. Bleeding disorder can be a cause, but it is not the most common cause. Endometriosis definitely not seen in pubertal menorrhagia. What are clue cells? Okay. So clue cells are basically, now this is how a normal cell looks like. Okay, this is the epithelium of the vagina. So this is the normal cell. Okay, these are the normal vaginal cells. Now, what is the difference between this and this? We can see that the surface over here is fluffy. Why is the surface, epithelial surface, fluffy over here? Because the membrane has been covered with the bacteria. This bacteria makes the membrane of the epithelial cells fluffy, and this is known as clue cells. Okay, so what are clue cells? They are epithelial cells with bacilli. Patient is on oral contraceptive pill. She presents with white pervaginal discharge. Now she has no symptom. There is no soreness, there is no itching, a yellow stain is there on the undergarment. Microscope shows large number of normal lactobacilli. So what can be the cause? So let's go through the differential diagnosis. Okay, if candida is there, then you just have to mainly look for two things: itching, presence of itching, and white cottage-like discharge. If bacterial vaginosis is there, then there will be gray discharge along the walls of the vagina. There will be fishy odor. In trichomonas, there can be strawberry cervix, right? Remember, and a frothy white discharge will be there. Pathognomonic of chlamydia is that in patients of chlamydia, they are not very symptomatic, but if they mention that there is dysuria, okay, more of urethral signs and urethral discharge, then the answer will be chlamydia, okay. So coming to the question, is it chlamydia? No. Bacterial vaginosis, so it was a white discharge, it is not a gray discharge, no odor. Candidiasis, there is no itching, so no. There is increased number of normal lactobacilli as patient is on oral contraceptive pills, so this is a physiological thing. Multipara presented with painless vaginal ulcer with previous stillbirth at 24 weeks. Okay, so you remember the sign which I was talking about, the Kasowitz law, right? So first of all, this refers to syphilis, that there was a stillbirth at 24 weeks. Also, there is a painless vaginal ulcer. So the painless vaginal ulcer can be because of syphilis or lymphogranuloma venerum. The only difference between this is that in lymphogranuloma venerum, there will be painful lymphadenopathy, which will not be there in syphilis. Painful ulcers are seen in chancroid and herpes genitalis. Okay, so coming back to the question, we will do first VDRL in this patient. Culture of ulcer and scraping of ulcer is not of much use. HIV we will do in these patients. We have to rule out other sexually transmitted diseases when syphilis is involved. So we have to rule out HIV, we have to rule out chlamydia. But that is not the first investigation. The first investigation is VDRL. Female with primary infertility with polycystic ovarian syndrome. She has hirsutism, BMI is 30. How do you advise her? She wants to conceive. Okay. So going through the question, finasteride metformin is generally not given. So finasteride ovulation induction also not given. These questions, option A and B are a little confusing. So weight loss and metformin, definitely going to go ahead with that. Now, whether do you give clomiphene citrate or urinary gonadotropin? So this patient is PCOS, right? And in PCOS, what happens? That LH is much higher than FSH. Okay, although we are not doing this test for PCOS anymore, right? LH FSH testing we're not doing, but basic physiology, LH is much higher than the FSH. Okay, now this urinary gonadotropin, it has both LH and FSH. Okay, and if the patient is PCOS, already the LH is quite high. So if we have to give ovulation induction, we will prefer FSH, not LH. Secondly, for when we start with ovulation induction, we will always start with clomiphene citrate. The best in PCOS had been if the option would have been letrozole. But since that is not the option, so we will go ahead with clomiphene citrate. If the patient is not responding to that, we will give her gonadotropins, but not urinary gonadotropin. We will give her FSH specific gonadotropin. All right. So this is the answer. Another keen to conceive patient, she comes, she is complaining of dyspareunia, dysmenorrhea. Bilateral spill is present. Bilateral spill is present means both tubes are functional, right? Both tubes are patent. There is restricted uterine mobility. So which means there can be some infection which is restricting the mobility, or there can be endometriosis also. So what is the investigation of choice? Investigation of choice is always to have a look as to what is happening inside, and we will go for diagnostic laparoscopy. Why not laparotomy? Because it is more invasive, and therefore we'll go for diagnostic laparoscopy. HSG, is it required? No, because it has already been mentioned that it has a bilateral spill. TVS again will not give us much clue as to what is happening inside. So this is our answer, which is incorrect. So vault prolapse, two things are done. Sacrospinous fixation is done vaginally. And there is another operation which is abdominal colpopexy. Okay, so this is also done, but this is an abdominal procedure. So this is correct. For uterine prolapse, hysterectomy can be done. Rectocele, there is posterior colporrhaphy, and it is very easy. This is urethrocoele. For urethrocoele, there will be anterior colporrhaphy. Okay, it is very easy. Rectocele is lying at the back, so posterior colporrhaphy. Urethrocoele is lying in the front, so there is anterior colporrhaphy. What is this colposuspension for? So colposuspension is generally done in patients with urinary incontinence. Okay, in stress urinary incontinence. So our answer is urethrocoele colposuspension. Fetal heart rate accelerations are due to, this is a very straightforward question, it is due to the involvement of the autonomic nervous system. A 16-year-old comes with a 16-year-old comes with a history of sexual abuse with her mother 2 days back, and what is the first thing that you are going to do? So again, this is a straightforward question. What is the first thing you do? You will always take a detailed history first. After that, you will take the consent for the patient and you will examine her injuries, you will collect her clothes. But the first thing that you do is take a detailed history. HRT causes all except. So what are the benefits and risks of HRT? HRT is your hormonal replacement therapy, which we give in which we give both estrogen, low dose estrogen and progesterone. So the benefits are that it decreases the menopausal side effects of vasomotor symptoms. It decreases chances of osteoporotic fractures. It improves the lipid profile of the patient, reduces the IBD flare. It has also been seen to reduce cases of colon cancer. It also reduces mood swings and the problem of decreased libido. Now, what are the risks involved? There can be increased chances of breast cancer, endometrial cancer. There can be general side effects like bloating, and there can be increased chances of thromboembolic events. Coming back to the question, the answer is it causes all are true except high risk of colon cancer. Banana sign is seen in. So banana sign is seen in spina bifida. Also another sign which is seen here is your lemon sign. So this is the ultrasound and this is the typical appearance of the banana. So this is the seen in spina bifida. A male presented with azoospermia, acidic semen and low fructose level. LH and FSH levels were normal. If LH and FSH levels are normal, it means that the hypothalamus is working fine. Okay. What can be the cause? The semen is produced in the testis over here. Okay. It goes to the vas deferens. Seminal vesicle adds fructose and the seminal fluid to the semen, and prostate adds prostatic fluid. Okay. Now, if there is a problem, if there is a pre-testicular problem, okay, if there's a hypothalamic problem, so your LH and FSH levels will be low. Everything is going to be low. Testosterone will be low. Your testicular volume will be low. Okay. Now, if there is a testicular problem, which means that the hypothalamus is releasing the hormones and asking the testis to produce semen, but it is not able to do so. So LH and FSH will be high because no matter how much it is producing, no matter how much LH and FSH it is producing, the testosterone is not being produced and therefore the negative feedback is not going. So LH, FSH is high, testosterone will be low and testicular volume can be low or normal. Okay. But if the testis is also fine, your hypothalamus is also fine, and there is some post-testicular problem, which means that there is some obstructive problem. So your LH, FSH will be normal, your testosterone levels are going to be normal, but still there will be some problem with the testicular volume because there is an obstruction at this level. Okay. So low volume acidic semen and absent fructose points to obstructive cause of azoospermia. The seminal vesicles are responsible for the production of fructose content and they also contribute to the semen volume. Now the last question, it was a really tricky one. Female presents with virilization. Okay, she has clitoromegaly, blind vagina, pubic hair is normal, breast is also there, Tanner stage 2, karyotype is XY. What is the diagnosis? Okay, now first of all, since there is virilization, it will not be androgen insensitivity syndrome. Okay, so it is not going to be this. Now what is happening in Swyer syndrome? Swyer syndrome, it is XY. The uterus is there, fallopian tubes are there, vagina is there, but there is no ovary. Okay, since there is no ovary, so the secondary sexual characters are not so well developed. Okay, here the patient has, the breast is Tanner stage 2, so this can also not be the cause. Also there was one more thing over here, that testosterone levels are normal. Levels are normal. Okay, now our two options are 5 alpha reductase deficiency and 17 hydroxylase deficiency. Okay, now let's go through this chart. Had it been a 17 hydroxylase deficiency, okay, so this thing is absent. So when this 17 alpha hydroxylase is absent, there will be increased production of aldosterone, there will be decrease of cortisol, there will be decrease of testosterone. So generally with 17 alpha hydroxylase, because of increased aldosterone, patient will present with hypertension and there will be hypokalemia along with other signs, okay, and testosterone levels will be low. Talking about 5 alpha hydroxylase deficiency, so 5 alpha hydroxylase, what happens, it converts testosterone to dihydrotestosterone. So over here the testosterone levels are going to be normal, right? And therefore the answer of choice when it says that testosterone levels are normal, it will be 5 alpha reductase deficiency, okay. Well, thank you so much. We come to the end of our discussion. Again, all the best for your examination results and take care.